You are sitting in a meeting and an administrator says, "We need to improve efficiency in the emergency department." Everyone nods.
including you.
What did they just say? Because what they said, what they meant, and what will actually happen when the efficiency initiative rolls out are three different things. And if you're not fluent in the translation, you will spend 6 months optimizing for the wrong outcome. I'm Chet Shermer, and I have been practicing emergency medicine for over 20 years. I have been a part of this process over and over in various settings and want you to understand fully what the message is and how it relates to us in the ED. When clinicians hear efficiency, they think high quality care, faster when appropriate, fewer unnecessary delays, better use of resources. That is what efficiency should mean in a clinical context. When administrators use efficiency, they are almost always referring to one or more of three specific operational metrics: door to provider time, left without being seen rate, and average length of stay. These are the metrics on their dashboard. These are the metrics tied to patient satisfaction scores and CMS reimbursement benchmarks. This is not a conspiracy. These are genuinely important metrics, but they are proxies for patient experience, not measures of clinical quality. And the gap between the proxy and the underlying thing it's supposed to measure is where efficiency initiatives go wrong. Door to provider time measures the elapsed time from patient arrival to first contact with a licensed provider. It is one of the most tracked metrics in emergency medicine. It is also highly gameable. Split flow triage, having a provider briefly contact every patient in the waiting room, dramatically reduces door to provider time without changing throughput, outcomes, or patient experience in any meaningful way. When an administrator presents a door to provider time initiative, the question to ask is, what problem are we actually trying to solve? If the answer is patients feel unseen when they wait, that's a communication and triage information problem, not a provider contact problem. Left without being seen rate, LWBS, tracks patients who register in the emergency department and leave before being evaluated. It is a real metric with real clinical implications. Patients who leave without being seen may leave with untreated emergencies and could represent an EMTLA violation. But LWBS rate is a symptom, not a cause. It increases when wait times are long. Wait times are long when capacity is insufficient relative to demand. Capacity is insufficient when boarding is high. An efficiency initiative targeting LWBS reduction that focuses on front-end processes without addressing inpatient boarding is addressing the symptom. You may see the LWBS rate improve temporarily. The underlying capacity problem remains. Average length of stay in the ED is perhaps the most complex of the three metrics. It captures everything: evaluation time, diagnostic time, treatment time, disposition, decision, and time waiting for inpatient bed availability. When length of stay is used as an efficiency metric, the implicit assumption is that shorter is better. Sometimes that's true. In fast track and low acuity settings, length of stay reduction often reflects genuine process improvement. In higher acuity cases, length of stay reduction may reflect clinically inappropriate shortcuts. The patient discharged in 3 hours instead of 6 may be returning in 12 with a complication that would have been caught on the 6-hour reassessment. Length of stay must be understood in clinical context. A raw length of stay metric without case mix stratification tells you very little about whether care was delivered well. Most administrators, when they say efficiency, actually want two things. They want patients to have a better experience, and they want the department to generate more revenue per square foot. These are not unreasonable goals. A department that sees patients faster, manages its census effectively, and operates without chronic bottlenecks genuinely provides better care and generates more sustainable revenue. The goals are aligned. The problem is when the measurement proxy is substituted for the underlying objective. When the metric becomes the goal rather than the indicator, you get a department that optimizes for the metric while the actual patient experience and clinical quality stagnate or decline. Three things. First, when an efficiency initiative is proposed, ask which metric is being targeted and what problem that metric is intended to represent. That question alone will clarify whether you're solving the right problem. Second, understand your dashboard. Know what your door to provider time, left without being seen rate, and length of stay look like. If you don't know your metrics, you cannot participate effectively in the conversation that shapes your department. Third, be the physician who can speak in metrics and in outcomes simultaneously. The administrator who hears the door to provider initiative will improve our fast track score, but won't address boarding because boarding is an inpatient problem, is receiving information they can actually use. This is Global MedOps Command, Clinical Brief Series. Efficiency is a real goal. The metrics used to measure it are imperfect proxies. Knowing the difference is what makes a physician effective in an administrative conversation. Next brief, what clinicians hear versus what administrators intend. Stay prepared. Stay educated. Out.